Good afternoon, everyone. Thank you, everybody, for their attendance today. It's really good to see so many young people in the chamber. Okay, so before we do introductions, I'll just do a little bit of housekeeping. So a fire alarm is not expected, but if the alarm sounds, can all present leave the building as quickly as possible by way of the nearest exit to the assembly point in the public square outside Cast beyond the fountain, away from the civic office. No roll call can be undertaken. Thank you. If anyone has mobility issues, please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. I'd like to ask if everybody could ensure that their mobile phone is switched to silent, please. This meeting will be audio and visually recorded and will be available to view on the Council's website and YouTube channel. Can I ask that all those present to use their microphones to ensure that we can capture the audio, please? And any members of the public entering the Council chamber will be accepting that their images will be retained and broadcast by the Council. I understand that there are no members of the public in attendance today. Is that right, Christine? Okay, so first of all, I'd like to say that we have got quite a few apologies for absence today, unfortunately. So we've got Antoinette Drinkhill, who's a co-optee, Councillor Bob Anderson, Councillor Sue Durant, Councillor Tracy Moran, I believe, and Councillor Laura Bluff, and also a young advisor representative. So we need to consider the extent in which the public and press are to be excluded for the meeting, and as I've said, we haven't got either of those in attendance today. Declarations of interest. If anybody has any declarations of interest, please declare this and a form will be completed following the meeting. Please contact Christine Rothwell, who sat behind me, and she will assist. Okay, so we need to agree that the last meeting on the 17th of June that we held it needs to be agreed that it's a correct record. When were you not here? We both were. Is that okay? Do you agree? Agree. Thank you. Right. So I think now we might as well go to everybody to introduce themselves, and then we'll be looking forward to any presentations, anything that you've got in store for us. Thank you. So do you want to start with Courtney? Thanks.
So good afternoon, everybody. My name's Courtney Helsby. I'm a participation officer and I lead on the Doncaster Youth Council, members of Youth Parliament.
Hello, I'm Kate Featherstone-Bennett. I'm the Service Manager for Quality and Transformation within Children, Young People, Family Service in the Council. I work very closely with colleagues across the partnership around children, young people's mental health and wellbeing.
Afternoon, Legal Service Director for Children's.
Good afternoon, James Perkins, Strategy and Delivery Manager for Living Well Services in Doncaster, representing South Yorkshire ICB.
I'm Holly Webb and I'm the Team Manager for CAM's Community Eating Disorder Service.
I am Wendy Green, Nurse Consultant for Adash Eating Disorder Service.
Hi, I'm Tom Brockwell. I'm Consultant Clinical Psychologist in the CAM's Eating Disorder Service.
Hi, I'm Angus and I'm a newly elected Youth Councillor and I'm also a SIMCO rep for Doncaster Youth Council.
Hi, I'm Fiona. I'm an ethnic minority rep and the Youth Councillor.
Hi, I'm Samri. I'm also an ethnic minority rep.
I'm Erin. I'm a SIMCO rep and one of Doncaster's MYPs.
Debbie Burton, Engagement Manager with the Partnership and Families team.
Fiona Lawson, Executive Lead Officer for Children, Young People and Families.
And last but not least, good afternoon, colleagues. I'm Rihanna Nelson. I'm the Director or Executive Director of Children, Young People and Families. Huge thank you for our young people that are here and a massive thank you for our health colleagues that's joined us this afternoon in the chamber. We're really looking forward to hearing what you're saying.
Thank you for the introductions. I should have probably said that I'm the chair of this panel and I'm Leanne Hempshaw, Councillor for Roman Ridge.
Hi, I'm Councillor Tim Needham from Armthorpe Ward and I'm the Vice Chair.
Steve Cox, Finelli Ward.
So I will hand over to the Youth Council.
Well, thank you very much for inviting us today to present our campaign plan to you. We've got a lot of ideas, so forgive us if we go on a little bit too long. So it's a huge strength we have here in Doncaster to be able to be taken seriously as young people and be able to meet our senior decision makers and leaders, because we know in a lot of other local areas they don't have this opportunity. So thank you for having us. Thank you.
So, since we last met with you all, we've conducted our Make Your Mark and Junior Make Your Mark consultation, and we would now like to share with you our results video.
Yeah, sorry.
The video's not working, but the video basically just explained what Make Your Mark is, which is a consultation around England, and it told us what our results were. So, hope you enjoyed the video that you didn't see. Thank you. We did that ourselves. But to give you a bit of context, in our recent youth consultations for Make Your Mark, we emerged as second in the entirety of Yorkshire and Humber, securing a remarkable 8,778 votes from young people across 41 schools, 6 farms and youth groups. With an impressive 30.1% of young people actively engaged, it's evident that our collective youth voice is powerful. With our top issue, crime and safety, which is a pressing concern for young people, which garnered 1,601 votes, our Youth Council is now leading the charge, championing this priority for meaningful change with a dedicated campaign, and are already initiating impactful project proposals for an educational offer including a film, lesson toolkit and posters. Our unique Junior Make Your Mark consultation emerged with an outstanding 6,351 votes in total across Doncaster, with Save the Environment coming up top with 2,152 votes. Our Doncaster Primary Ambassadors and Junior Civic Mayor are championing this issue, formulating a campaign to raise awareness and embrace positive change. In total, we had 15,129 children and young people have their say, which is an increase from our 2022 results when we got 12,185 responses. As you can see, for Make Your Mark, crime and safety came up on top, followed by health and wellbeing and then education and learning. In the Junior Make Your Mark, Save the Environment came out on top, followed by discrimination and bullying and then road safety.
So moving on to our next campaign, #EditViews, which is an eating disorders awareness campaign, which myself and the other youth councillors have been working incredibly hard on and excited to share the work. So we were going to play a video, but obviously we're having technical difficulties, so that won't be happening. But the video just briefly sums out youth voice that we gathered, clearing misconceptions and having official sources being credible in our research and findings. Why? So the Doncaster Youth Council have been working on an eating disorders campaign which came from the 2022 Make Your Mark results top issue, mental health and wellbeing. We then did a deep dive identifying eating disorders as the main area of concern for young people. As a result, we wanted to meaningfully tackle this sensitive issue, carefully creating low-level early intervention resources to raise awareness, promote healthy attitudes towards body image, the importance of talking to others and free support services. By raising awareness and providing basic education, young people will be able to recognise early signs and symptoms in themselves and others and know what to do.
So, professional collaboration. We had the privilege of collaborating with a nurse from the R-CAMS Eating Disorder Service, also visiting the clinic in Conisborough. This invaluable partnership allowed us to gain professional insights, ensuring that we were equipped with reliable information and knowledge. We have met with health professionals who have approved our campaign messages, including how we have not focused on food, as eating disorders are more than just about food, but have targeted young people on a universal level as early prevention, advice and awareness. We did consider extending our campaign to younger children, but when discussing with professionals, we will need to take very careful consideration and professional guidance. This may be something we could consider for the future.
the South Yorkshire Children and Young People's Alliance Conference 2024. So in the May half term, we attended this conference in Sheffield. This year's theme was around breaking cycles, and we chose to do a workshop presenting our #EditViews campaign, resources and learning bingo game to young people, partners, service and strategic leaders from across South Yorkshire. It was a fantastic platform to showcase our work and advocate for young people in Doncaster. And if you haven't noticed already, that we have actually an article in the Free Press, which is really exciting and cool.
So as part of our campaign, we wanted to make some awareness resources. So first up, we've got posters. So we designed posters to go into schools, young people settings and social media to echo our campaign messages with positive affirmations, tips and free services for young people to find support. We have made an easily accessible poster for anyone to order information packs from Beat Eating Disorder Support website for free. As a result, we are equipping young people, families, friends, teachers and youth workers with the knowledge to support anyone struggling with body image, mental health and well-being and EDs.
We also, just like the posters, created banner pens, which allows young people to access sensitive information discreetly. This is important for topics like mental health and well-being, where young people may feel embarrassed or stigmatized. These pens are compact, portable, and easy for young people to carry with them, which increases the likelihood that they will refer to it when needed. They pull out the banner. The banner will attract attention and curiosity, which will encourage young people to read and engage with the information at their own pace and comfort. Not to mention, it's a functional item with black ink so young people can use them in school, and also who doesn't love a free pen?
We have also designed and made our own pin badges so that people can wear them and carry our long-lasting campaign messages. It is our dream to make sure as many young people in Doncaster and beyond have one of our badges, and we have lots of variety.
So we've also got some learning activities as part of our campaign. So to start us off, we've got bingo. Our game can be played in groups with young people winning prizes, which can be varied depending on who's delivering it. It is also useful in reinforcing correct information while also challenging stigmas and misunderstandings.
We also have a learning word search. So word searches offer therapeutic benefits, including helping to reduce stress and anxiety. The feeling of satisfaction when finding words makes it a rewarding activity, which is why we developed our own learning word search. Word searches are simple to understand and can be used across different age groups and educational levels. This activity is best for a more relaxed learning environment as well as in a group. When young people are finding the words independently and repeatedly searching for them, they are more likely to remember them in the future.
We created a positivity tree, so it's a collaborative activity where everyone writes positive affirmations and advice they would give to somebody on a colourful tag to place on the positivity tree. Benefits include young people thinking positively about themselves and others as well as the world around them, resulting in a lovely colourful tree that is filled with pride, which we also did this activity at the conference, which you can see in the images on the presentation.
So for people who don't have a physical tree and TAS, we've created an activity sheet that does not involve any of those equipment. So all you need is one of our activity sheets, a pen or lots of colourful pens, and doing the exact same thing but individually recognising and creating your own positive affirmations to take home to remind yourself or to give it to someone to brighten their day.
So our gratitude attitude activity is good for small groups, in pairs or on your own. It's all about expressing gratitude for things in our lives, no matter how big or small, which many of us sometimes take for granted. It encourages young people to positively reflect on themselves, their strengths, who they are, places and the people we have around them who support, care and love them. All you need to do is roll one dice or two to match the sum to the answer. The prompts, taking it in turns to share out loud or write it down. By using the dice to randomly pick statements adds excitement and spontaneity, encouraging young people to think on their feet as they answer lots of different questions. It will enhance social interaction, empathy, understanding, bonding, positive mental health and well-being and supportive atmosphere.
Fact or myth? Our fact of myth game is best suited for small and large groups and is an interactive and engaging way to educate and raise awareness on EDs and mental health and well-being. This game helps tackle misconceptions with the simplified format, making the decision-making process quick and easy, encouraging critical thinking, as well as promoting mental health literacy and a supportive learning environment. In turn, it will reduce stigma, encourage open conversations, and makes the learning more interactive and memorable. Once completed, the group leader will read the answers with a sheet of discussion points to go with each statement, which is found in the guidebook.
So to go alongside our campaign, we have created an #EditViews guidebook to support our learning resources and offering educators, youth workers and staff guidance to support young people. The guide includes answer, instructions and tips on how to play our educational games and activities. When a young people's setting signs up, they will receive our guidebook.
So a lot of information has been thrown at you of the work we've been doing, but that just shows how much we've been working on it and how we're proud of our product. So our next steps, we are working on finalising our learning activity package ready to deliver. Once fully finished, we will be sending our packages to professionals to be fully signed off. Our ambition is to work with educational settings to have EditViews ambassadors and to help them to develop their own methods to promote the messages in our campaign. So for example, having a mental health and wellbeing advice and guidance wall in schools. Integrating our materials and messages to complement the work of the Eating Disorder Service and school nursing team and what they deliver. Also, we would love to have a launch event showcasing our campaign locally to professionals, services, key decision makers, and young people. So that is to conclude our #EditViews campaign. If you just have any questions, please hold on to them as we're going to move on to our crime and safety and pride campaigns. So thank you.
Yeah, so now I'm going to be showing you our plan for our crime and safety campaign. So this is going to be a very important part of the overall campaign, as I believe crime and safety is a very large problem in Doncaster. So we are doing a campaign due to crime and safety coming up top on the Doncaster Make Your Mark with 1,601 votes. Doncaster youth councillors have consulted and gathered youth voice with other young people in their communities to delve deeper as to why young people may have picked the issue and what it means to them. So these are the reasons why people voted for crime and safety and the issues that made them feel unsafe. So we've got gangs and fighting, which I think is one of the most common, and also the people who encourage them and video it, as well as bystanders not knowing what to do. We've also got knife crime, which is increasingly common with young people, and was also one of Oliver Coppard's aspirations to reduce if he became South Yorkshire Mayor, which he has. So hopefully he's going to be able to reduce that. So this is just the local areas in Doncaster. You can see central Doncaster was the highest voting for crime and safety. So these are the key areas identified by young people where crime is happening. So basically on the way back from school or college, buses, town centre, French Gate Centre, outside Doncaster train station, bus interchange, tunnel near B&M, Lakeside or Hatfield Park. And as well as the other issues I mentioned earlier, there's also bullying, vaping, online safety, and antisocial behaviour. They're just some of the other ones. So our aim is to complement the early intervention work that has already been happening in Doncaster. So aiming to empower young people to think critically about their choices and the impact of their actions. Educating and highlighting the importance of making safe and responsible decisions when faced with a difficult situation and the ripple effect it has on them and those around them. Resulting in young people being more informed to take choices that lead to better and positive outcomes. So the key themes are going to be fighting, getting jumped, gangs, knife crime, being a bystander, and not knowing what to do in the situation. So the plan involves a film, which is, we've already made one similar, we're going to make one similar to the domestic abuse film that we've already made. I don't know if you've seen that. Also a toolkit, posters, safe spaces in town. So we're going to try and make a similar strategy to the Ask Angela technique. I'm not sure what you know what it is, but we're going to try and make one of them as well. How educational settings, youth forums, youth groups, the grid, social media, and cinemas and bus stops. And then obviously our target is young people aged 11 to 18, and then when, fingers crossed, early next year. So the film concept is going to be set in the city of Doncaster in different communities and neighbourhoods to ensure the settings are relatable to young people, emphasising common places like schools, parks, bus interchange and streets. Following the stories of 3 young people who all engage in the same situation, altercation, which forces them to make a choice, and we follow each of their journeys from their perspective, as well as the consequences that come with their choice. By grounding the story in Doncaster, the film will resonate with young people, providing a realistic backdrop for the characters' struggles and decisions.
At the end, we'll have a sliding doors concept of what they could have done instead, emphasising that the characters are just normal young people, just like them demonstrating what to do if they are ever in a similar situation. We want to feature police and settings to emphasise that they are here to help and assist in keeping everyone safe, reducing the stigma against talking to authoritative figures, also leading to the film's credibility, making it more trustworthy and impactful. At the end of the film, taking a moment to display information to emphasise services young people contact for help, to report or seek support, and any apps you can download on your phone, such as WalkSafe.
So, in order to make this campaign possible, we have been awarded £14,000 by the Violence Reduction Unit, which is absolutely amazing, and we're really, really grateful for that. So, yeah.
So we've also been doing Young Person's Guide to Pride. So our LGBTQ plus reps on the Youth Council have collaborated with our LGBTQ reps youth group in the council. We have started working on developing a Young Person's Guide to Pride leaflet to launch at the Pride event in August. Its content focuses on how young people can keep themselves safe when attending events, with suggested tips such as not giving out social media details to strangers, what LGBTQ stands for, and support services young people can go to for support and guidance. The Youth Council would like this to be a legacy project that can be used all year round to support LGBTQ young people.
So yeah, I'd just like to say a massive thank you for inviting us today. It's been a great pleasure, and just thank you for letting us present this to you. And if you've got any questions, be sure to ask us and we'll do our best to answer them. So thank you.
Thank you very much for that. It's brilliant. I love the banner pens, by the way. I think they're absolutely great. Yeah, a bit dangerous, maybe, for Tim anyway. Yeah, I like the fact and myth side of that. And it's just great to hear how many young people got involved in the voting and giving their feedback. But I just have a question around... Is it young people talking to young people, and what sort of roles do, adults play in that, or are you quite sort of allowed to just get on with it and feel that it works better when it's a young person talking to a young person? Thank you.
So our consultations are always youth-led. We will come up with questions to make sure they're meaningful and young person friendly. And we take them to our schools, colleges and sixth forms and share them on our social media as well. We know we don't have strong links in every community and area, so our participation officers and youth officers go out to community groups and schools and advocate on our behalf when we can't be there.
Thank you. Has anybody else got a question?
More of a statement, really. I thank you very much, and I'm sorry our colleagues aren't all turned up to listen to your fantastic presentation. I just wish you luck with it all. I mean, growing up, it's tricky for us all. Mine were a long time ago, but I remember some of the stuff that were going off in Stainford at that time, and it were hard work to deal with. And yeah, I just wish you luck, because there's a lot of similarities now to what were then, unfortunately.
That's me. I'd just like to say congratulations on the increase of completed surveys and capturing even more young people's voice, because I know how hard that is. As an old ex-tax youth worker who used to go around with a bag full of getting young people to fill them in, I know how hard that is, so that's tremendous. I also noted, and I'm pleased to see a good response from young people at Armthorpe Academy, because that's obviously my ward, And yeah, I'm very pleased that that involvement is increasing, and also an open invitation that at Armthorpe Parish Council we've got an Armthorpe Youth Parish Council, and I think that's quite unique. But you're more than welcome at any time at all to come along and support our young people grow. So that's a wonderful thing. So well done, everybody. And I do have a question because I'm interested in safe spaces, and I wondered if you could give me I don't know about it. So what does that mean? What does it look like? Is it like a... Well, I don't know. I'll leave it to you, but I'm very interested in that.
Well, I'm not, I know there's a thing called the Ask Angela technique, which is, I think it's for mainly females, where if they feel unsafe when out and about, they can go into a bar and be like, is Angela in? Which basically means, basically making a young person equivalent. So maybe putting a sticker on the front of a shop and saying, this is a child-friendly space, if they feel unsafe. But, figuring out something like that, but I think that'll be really effective.
That's great. I like that idea. In my narrow mind, I've got a notion that they were like a collection place or a safe place where if you were worried, you could just go to. So, but yeah, I'm liking that idea. Debbie, do you want to talk?
Yeah, I was just going to say, our young advisors couldn't make it tonight, but they lead on that child-friendly campaign. So they're the ones that are picking this work up, working with our youth council, and I think they're going to target spaces that youth council have identified, such as the interchange and French Gate, and they'll go to them and get that child-friendly kind of charter, and then they're hoping for that sticker in that window of that shop that's completed that child-friendly initiative. So very much like the Ask Angela, it's going to be child-friendly, but it's a Doncaster child-friendly that's been created by our Doncaster Young Advisors. So it's all Doncaster-led, young people-led.
That's fantastic. And I do realise I ask questions, but I'm not afraid of the answer. So if the answer is, I don't really know, that's absolutely fine. Okay, thank you.
Can I just ask as well that you did mention that you'd got the money from Violence Reduction Unit and you're going to make a film. But is there anything else that you're going to be doing with that money, or will that take most of it up? Because I know the domestic violence film, I think it had its own premiere and it was on, on side of buses and in our Doncaster cinemas. So I wonder if this is going to be a similar thing.
I mean, I think it is. The film's going to cost most of that 14,000, but I'm pretty sure it's going to go to all, like I said, we're doing posters and stuff. It'll go to that, but most of it will be on the film, I reckon, yeah. But I'm not completely sure.
And possibly a limo to the premiere. A red carpet, I think. I'll have a word with Debbie for that one.
That's for Rihanna, isn't it?
Yeah, Rihanna would like to have a walk down the red carpet, yeah. So I don't know if you want to add anything, Lee, on this work before we do this part of the recommendations.
Yeah, thank you, Chair. Well, just to reiterate how proud we are of our young people. I mean, it never failed to amaze us with the amazing work they've done. It's a shame that we're not able to show the videos because there's some the messaging that they've put in there and the sensitivity of which they've approached it, in particular around eating disorders, is really commendable and actually will make a real difference for some young people. So I think we're very fortunate in Doncaster to have forums for young people, such passionate, knowledgeable and intelligent young people that, whilst keeping us on our toes, as you absolutely should do, just do some amazing work, really. That's it, thank you.
Thank you. Would it be possible for members of the panel to have hyperlinks so we can watch them? Thank you.
Yeah, I was going to ask that, thank you. It's just that I do need to read out a couple of recommendations for this part, and I understand that there might be some young people that will leave for the questions on eating disorders, so that's fine, whoever needs to leave. But first of all, for this part, we would say, does the panel feel that we've given good consideration to the information presented that includes the eating disorder, edit views campaign, crime and safety campaign, and the work plans around LGBTQ agenda?
Yes, I think so.
Yeah. Thank you. Okay, so we'll move on to the second part of the meeting in just a second. Okay, so we're going to the second part of the meeting. I'd just like to give opportunity if anybody wants to do any presentation before we have got a few questions.
Just to add a little bit of context, really. So, the eating disorder services in Doncaster are clearly a partnership issue, but are commissioned by the ICB, so it is health funded. Obviously, as a local authority, we've got a responsibility statutorily through Rihanna's DCS, but also as system leaders. So whilst we're not directly involved in the commissioning of the services, we do very much see this as a partnership issue. I just wanted to flag that. That's okay.
Thank you for that.
Okay, hello, and thank you for having us. So we've put a short presentation together to kind of explain our story as a service and illustrate what we offer. So I suppose it's important to think about the development of services in Doncaster in the national context. So it kind of started in 2015 with a national children and young people's eating disorder programme, and attached to that were a set of national guidance which included what treatment should be offered, but also timeframes within which, for example, referrals should be triaged and treatment should be offered. So that guidance very much shaped the formation of our service and about 70 other services that look very similar to ours developed around the country at around the same time. So we launched in 2017. I should also say actually that the guidance very much focused on community eating disorder services being a specialist service where they sit separately to community CAMHS teams. And the rationale for that was that community eating disorder services were evidenced to manage higher levels of risk relating to eating disorder in the community and therefore reduce inpatient psychiatric admissions, which obviously had a massive social and economic costs. Yeah, and then I guess as well the focus being on intervening quickly. So access and waiting times standard was very much about services intervening within 4 weeks from the point of receiving a referral, because that timely and quick intervention is the biggest predictor of positive outcomes when working with eating disorders. So as a service, we launched in 2017. And as Lee was saying, we're a service that covers Rotherham, North Lincolnshire and Doncaster, and the footprint for that was that we would have 100 referrals across that area. I think Doncaster probably would equate to about 40 of those a year. And that was about when we started, that was about the level of activity we were getting. It steadily increased over 2018, 2019. And then COVID hit, and there was a massive increase in referrals. It was for Doncaster, it was about 3.5 times. So I had the figures went from, in 2019, we had 49 referrals in Doncaster, and in 2021, 170. So there was a massive increase in referrals. And at that point, the service structure we had wasn't able to meet demand. We had a lot of the referrals when they were presenting as well, the young people had much more complex presentations and were more physically unwell often as well, perhaps because they'd not been seen by services during lockdown, and I guess the kind of social isolation increased influence of social media on our lives that we all experienced during that time. So 2021 was more kind of, I suppose the impact of that was we were still living as everyone was, and we continued to have higher levels of demand. We weren't able to meet that, and as a service we were breaching those access and waiting time standards. I think our kind of average waiting time in that time was about 12, 13 weeks. And there were conversations with commissioners around that time, and there was some additional investment which allowed us to recruit more staff and bring those waiting times down. So so that kind of was towards the end of 2022. Since then, we've been, as a service, we've continued to meet access and waiting time standards at least within so there's a national KPI of 95%, and we routinely achieve that target. But the numbers of referrals have stayed high, so throughout 2023 and into 2024, numbers have remained high, but also the kind of, I think probably related to the impact of the pandemic, we're continuing to see high levels of clinical complexity and physical health risk. We would, part of the, I'll come on to the kind of service offer in a minute, but into the future, we would very much like to support, look at service developments and look at provision for avoidant and restrictive food intake disorder, which is an area that's not currently, and this is part of a national picture, is not an area for which there's widespread support, and look at what we can provide in terms of more intensive community support to reduce inpatient, acute and psychiatric admissions. So in terms of what the service looks like and what we do offer, we're a 0 to 19 service, and we're commissioned to deliver interventions to support young people with anorexia, bulimia and binge eating disorder. We also have a service and eating disorder awareness raising and training function. That was something that we really struggled to continue over COVID due to social distancing, but also the increased clinical demand on our service. We, as a service, are really proud that we're focused on patient need and promoting ease of access to service. So we're very much not a service that has specific BMI criteria or something like that, which some eating disorder services do. And if a young person is referred to us and we feel that they're at risk of developing an eating disorder, or we feel that we might be able to offer some appropriate support, then we work with that family to get them into service as quickly as possible. So we triage referrals for urgency within 24 hours. So our routine target to offer treatment is within 4 weeks from the point of referral. But if there are increased physical health risks or mental health risks, then we potentially see people within a week for an urgent referral and within 24 hours for an emergency referral, which is typically when young people are presenting to paediatric or acute health wards. We are a multidisciplinary team, and we offer assessments and interventions the same within 4 weeks, and we have the more urgent criteria as well. And we're looking at, we offer support for parents and parenting groups, and we have some other group interventions, including multifamily therapy, which is a kind of adjunct to family therapy and family-based approaches, which is the kind of bread and butter of our clinical work. So in terms of what's working well, we typically meet the access and waiting time standards. We have a really diverse and experienced multidisciplinary team. A high proportion of our team have access treatment to recommended treatments by in relation to clinical guidelines, which are principally family-based approaches, also some individual models of therapy such as CBT. We are in a kind of, what we're doing currently in a post-COVID world is increasing our training and awareness activities. We're in a place where we're able to restart that, and I think the EDIT campaign is a kind of has given us a nudge as well in terms of actually that's a great campaign that we want to build on, and we're looking at we're in the process of redesigning some of our service promotion materials and looking at targeting education and GPs, etc., with both materials and offers of training. We typically have had low rates of inpatient admissions post-COVID, and also I guess this has kind of come from COVID and the pressures on the service at that time. We've developed closer closer relationships and working partnerships with, for example, DRI and our crisis team, intensive home treatment team. We also, in relation to another kind of factor that was apparent from COVID was the increase in neurodiversity being observed within young people, I mean broadly, but certainly in relation to young people referred to our service. When we did an audit of our caseload probably about a year ago, about a third of the young people on our caseload either had been diagnosed with ADHD or autism or were awaiting assessment of those conditions. So in response to that, we've developed a pathway whereby we refer from our eating disorder service to the CAMHS neurodevelopmental assessment pathways, and we share resources in that assessment so that there's shared clinical knowledge and efficiencies in those assessments. We've also implemented physical health clinics, so we've got a healthcare support worker who's fundamental in that role in terms of doing ECGs, and we're shortly to develop taking bloods within our services as well. And we're working closer with SAIDA, which is the South Yorkshire Eating Disorder Association. So we've now got a weekly, it's not used every week, but it's a weekly slot to discuss referrals and also sharing of training and awareness activities. So SAIDA have a quite comprehensive kind of training offer that's available online, whereas the training and awareness stuff that we tend to offer is more of a bespoke to meet the needs of a particular college or the particular setting that is requesting it, or the paediatric wards, which SAIDA wouldn't be well placed to provide. In terms of challenges, I've probably jumped ahead a little bit in relation to this, but we've got an increased number of children and young people presenting with long-standing difficulties, and there's a small number of people that kind of first presented to us during COVID that have very kind of severe and entrenched eating disorders that are still open to our service, and in some cases still accessing inpatient psychiatric care. And we still see some young people present to service kind of late on in the onset of their illness as well. That's a kind of a pattern which hasn't dissipated since COVID. I've mentioned the increased numbers of neurodiversity within our caseload as well. Other challenges include, so I guess part of the national programme delivered a very comprehensive training package to all the services that launched around the same time as us, and since then the kind of the repeat training in order to get new staff into service or to kind of cope with staff turnover has been a bit slower. So typically there's about one training a year provided by a national team, which we're able to send new staff onto. And we're obviously able to help support the development of new staff that come into service, but in an ideal world that would be a higher frequency. And also in terms of, again, this is a national picture, and I think because of the implementation of the Children and Young People's, the national project, but also because of the increase in demand on services and the rapid expansion of community eating disorder services like ours, there isn't the staffing pool to recruit into those posts. So often it's quite hard to recruit to vacancies when we have them. But I think we're challenging that. We're developing relationships with universities, with other teams, and trying to support recruitment into our service. And I'm sorry, I've written local provision with acute hospital wards. I'm not sure what I meant by that. Have you got any ideas?
Maybe. I wonder whether that was something in particular about kind of where children and young people are best placed on medical wards. So potentially we can have someone who's 16 years old on an adult acute ward. So I think potentially it was about the challenges of actually that's not for us to make a decision on. We don't have the authority to make those decisions. But we would certainly have a preference on where children and young people would be best suited and be best cared for.
Thank you. But that's the end of the presentation. Thank you.
Thank you. I mean, we had some questions set out obviously before we came here today, but just listening to you talking, I've got a few others. So just to, the last thing that you were talking about, where children get placed when unfortunately they end up in the hospital, DRI, obviously we're talking about Doncaster Royal Infirmary. What can you do then? Who would be responsible and work together to make sure that those children don't end up on, say, adult gastro wards, or, what are we doing to make sure our hospital can accommodate these young people when you're talking about these high levels of eating disorders that you've explained?
I think as a starting point, we need to accept that it's a medical hospital that has its own pressures on beds in the same way that lots of other services have pressures. I think in terms of children and young people with eating disorders, we've built some really good links with DRI, and we're in the process of, in fact, I think it's about finalised a pathway between the two of us in terms of how we work. In addition to that, we've had some changeover in the governance and structure around managing medical emergencies and eating disorders. So in terms of the framework that we use to assess medical risk and manage medical risk, we have the new guidance now, which is fully embedded across the hospital and with a pathway in place for that. And I think that will help us in terms of finding out where's the right place, the right unit for a person to be in. I think there's always going to be difficulties in where people sit. They have pathways that we aren't able to necessarily influence, but I think we're working a lot better now in terms of being able to be more flexible with that. And I think the Mead guidance helps with that. So the Mead guidance talks about where a young person should be based on their presentation, not necessarily by an age criteria. Does that help?
Not really, to be honest, because I'm not blaming any one party in this, but we need to, looking at it on paper, this is a real problem. So we need a structure in place to make sure that we're not hearing these nightmare stories of these young people, like I say, ending up on, say, a gastro ward in an adult ward. I mean, I would presume somebody under 18 would be in the paediatrics department anyway. Is that not right?
Not necessarily. So currently the ages at DRI are 16 and above as adults. But I think we also need to bear in mind that sometimes an adult gastro ward is really appropriate. I think what we need to work on and improve is how that care is managed when they're there, because actually an adult gastro ward at DRI has some incredible skills that are really valuable in managing eating disorders. So I think it's important that we recognise where the skills are and think about how we can influence the care pathways around it.
I don't know if some others might want to ask a question, but just going, because we're on this medical line, I mean, we've got ICB here, we've got a wellbeing board that this could maybe be, taken there for further discussion. But, when you talk about ECGs, which I think is the test to make sure the heart's okay, is that right? And do blood tests. What do you mean? Do you mean that you've got the capabilities within the CAMS setting to carry out those medical tests? Is that what you're saying?
Yes, we do. So we do that in our clinics in the community, or if needed in somebody's house. If we needed to, it would be more appropriate, usually in clinic. But yes, we have the capability to travel with that and take that to where it is. And we have a service that interprets that and will respond to that. From there, we can escalate if we need to. But I think sometimes for us, the importance of that was not only managing and recognising the risk, but also reducing unnecessary admissions. So having the capability to do those tests in the community means that we can reduce admissions that aren't necessary.
Yeah, thank you for that. I want to go to Councillor Needham then for his question.
Hi, thank you. So my question talks about multidisciplinary team working well, and it was paragraph 15, page 15. And so in terms of that, where does multidisciplinary work take place? Is it in localities or is it in city centre, and what kind of buildings? And do partners come together to reduce the amount of re-explaining? So if you say you've got 1/3 of your people who are neurodivergent, well, nationally it's 50 to 20%, so that's about right. How does that play? Is it like one person, one member staff, one plan that? Because, and also going back to what Councillor Empshaw said, if you've got young people who are 16 to 18 and 1/3 of your caseload are neurodivergent, then they're really going to struggle in an adult ward. And so I'm interested in partnership work, but I'm also interested in where's the child's voice? Is that recorded? What does it say? And what are we going to do about it?
Thank you. So I guess as a starting point, all of our children and young people in service have their own personalised care plan that's written with them. So our care plans are co-facilitated, they're written in ways that are thoughtful, and the young person's voice is very clearly heard in there. We need to be aware that as a service, and given the complexities of the illness that we're working with, there are often more than one professional working with that family, and that's important. In terms of kind of working across, you talked about reducing the risk of retelling their story. It's something that we're really aware of. As part of reducing that, we have our MDT every week where we'll share some of that background information. So if there is another professional that needs to be involved, our young people are aware who's coming, what they know about them before they see them, what work has been undertaken in the background to make sure that that risk of re-explaining is reduced. But sometimes it's important to remember that other professionals will need to be involved. I guess going back to the first bit of your question, you asked a little bit about the buildings and where we see people. So we have a primary base in Conisbrough, and the majority of our clinical work is out of that base. It's important to remember, I guess, given the level of clinical risk that we hold in the community, having a central base for us is really important. Having that kind of peer supervision, making sure that colleagues are there, making sure equipment is there, and being in the right place to keep a young person safe is really important. But alongside that, we've got the capacity to work in people's homes, in schools. We'll frequently see people in schools, in GP centres, in anywhere that young people need to see. We've also got the ability to support people to get to us in other ways if they can't. So if there's challenges with transport or with funding, we'll support with making sure that people can get to us and there are no barriers to treatment. Thank you.
Okay, thank you. And that's interesting to hear. And also in terms of additional support, is that linked in with other partners? So, for example, is it linked in with early help? Is it, and that could be a school, could be city council, could be anybody. And so in terms of that, because sometimes behaviours are there for a reason, and there's a multiple raft of reasons. So in terms of early help strategy, does that fit in?
I think the short answer is yes, absolutely. And we're really keen to work with partners. We'll work alongside early help. We've got early help coordinators across CAMS that we'll link in with as well. So yes is the short answer.
I'm delighted to hear that. Thank you.
On that, which I would reiterate, there is further work for us to do though when we think about shared assessments, telling voice wants, what that looks like. So there is variance across council services, across health services, but that's very much on our radar as a mental health strategy group. So it's just how do we simplify the messaging and the assessments and the planning for families so they're only telling it once. And actually the best placed person is the person that holds and supports that family. And actually, especially services, be that social care or in this case eating disorder, they step into support and step away rather than a step up and a step down. There's more work for us to do on there, for sure.
It's a massive area, isn't it?
Yeah.
I'm just keen that young people and families' voices is recorded, and that's got a real influence.
Yeah.
Thank you.
Yeah.
Thank you. So another question is, I know we've talked quite a bit about the significantly increased cases sort of during and after COVID, but I just wondered, I mean, it sounds self-explanatory, but could you sort of tell us a little bit more about the rationale about why that is, and how much does a need for maybe some control over their own lives? Is it sometimes about control and feeling out of control because we're living through a pandemic and you know, I mean, we all know what that was like. It was changing daily. We were hearing about how many deaths each day. Do you think that's part of it, that maybe that triggered something in that young person to want to have that control?
I think it's important to recognise that there's been lots and lots of research into causes and influencing factors for eating disorders, and there's no kind of, you know, firm evidence for what causes an eating disorder, and it's always individual. As you know, there are biological factors, there are psychological factors, and there are social factors. Obviously, the pandemic was a massive change in social factors. I think social media and the rise of social media and how easy it is to access social media is something which is probably influencing the rise that we've seen locally, but is also experienced nationally, internationally, in terms of people struggling with eating disorders. I think also in relation to the pandemic, there was a lot of health anxiety around around COVID, but also I think that translated into other health conditions. And we've certainly seen, and this is risks being anecdotal, but I think we've seen young people in services who have wanted to avoid physical illness through overly focusing on health. And I think there was a lot of emphasis nationally on focusing on health and remaining active in a pandemic where we were locked inside and didn't have access to the same facilities as we would normally. There's also, and you asked about control, I think there was a lot of lost control. And I think, again, anecdotally, I think control can be a factor in anyone's experience of an eating disorder, because it's kind of, in some ways, the very last thing that you can always have control over is what you eat and what you don't eat. It's very hard for someone else to influence that. So yes, I think control can be a factor. When I read the question in terms of the academy model, would you be able to say a little bit more about that in terms of what you were interested in?
Yeah, I was going to do it as like a second part to it, but just wondering, I mean, you speak to these young people and you must sort of, I'm not saying directly ask them why they feel that they're struggling with an eating disorder, but there must be, at some point getting down to why they feel that maybe this is happening to them. And I just wondered, how much would maybe the academy model come up, where we do see a lot of young people struggling with how academies operate these days, especially neurodiverse children. It's a lot of pressure, a lot of exams, just things, just the way that academies are run these days. I wondered if, I know a lot of young people I speak to do feel like they don't have much control of their school life, so then sometimes behaviours happen in the home life because it compensates for that lack of control while they're in the academy.
I mean, I think that's a narrative that we have also heard within service. I'd feel unable to say whether that's something which is kind of an influencing factor more broadly than those kind of anecdotal observations, really. So I suppose I'm thinking about education settings that aren't encompassed in an academy model, and I'm not sure we could compare a non-academy versus an academy and say that there's necessarily differences. I think school environments there's a spectrum of how controlling or restrictive they could be, and I think sometimes that can impact someone's eating difficulties, particularly if there's neurodivergence, perhaps. I think also the way in which schools choose to implement curriculum based on health and healthy eating can potentially be problematic. But again, I'm not sure if that's related to an academy model or to education as a whole. The short lunch breaks that some schools have, again, not sure whether this is related to academy or not, is certainly a difficulty for some of our, for a number of young people that we work with. If there's half an hour for a lunch break, and in that time that's the only time they can go to the toilet, and they've got to queue up, and they've got to eat, that's placing physical restrictions on something which is already a challenge for them.
Thank you. Yeah, that is interesting. But as a professional, what would you say are the influencing factors
on eating disorders? I mean, it can be anything, I think would be fair to say. I think an eating disorder can present as someone's strategy for managing distress, in the same way as self-harm can, or in the same kind of some people might be more prone to experiencing psychosis. Some people might be more prone to experiencing anxiety disorders or depression, and eating disorders are very much, they're a mental health condition in the way that they present as a response to distress, and if it depends where that distress comes from. I mean, it could potentially be anything. I think control can be a factor. Social media and social pressure and social comparison is certainly a factor. Sorry, it's a really tricky question to answer. What causes an eating disorder? And the research evidence is that lots of different things influence the onset of an eating disorder. Nothing causes it on its own.
Yeah, I thought that, but I mean, we're here to just ask the stupid questions, if you get what I mean, because you live this is day in, day out for yourselves, but knowing very little about it, it's just, I just find it quite interesting just to, I know there's not an answer really, is what I'm trying to say, but I just wondered what kind of things that you see. But I think we'll move on and just kind of just on that same vein, when we talk about neurodiverse young people, I mean, often people think an eating disorder, I think if you don't know much about it, is probably about body image primarily. But I think, as we all know, not all neurodiverse people, but there is that element of maybe textures can be an issue for neurodiverse, or they don't want food touching on a plate. So, it's vast. That's what I'm trying to get at. So I just wondered how you see that correlation between neurodiverse and eating disorders. Do you think those numbers are quite high within those numbers of a young person presenting with an eating disorder?
Sorry, I'd also in response to your previous question as well, I think it kind of links into why the child and the young person's and the family voice is so important, because there are no clear answers of what causes an eating disorder. That's one of the reasons why that is central to our service model and what we do. Sorry to go backwards a little bit there. In relation to neurodivergence, there is nationally there is an overrepresentation of neurodivergent young people within community eating disorder services. I think some of that is in response to lockdown and the kind of the aftermath of COVID in relation to young neurodivergent people who were in an education setting and had kind of got used to that routine and that structure, then had that taken away for a year. And I think the transition back into that level of structure and routine with the rules we had around social distancing and things were a particular challenge for neurodivergent young people. And because of that, they've presented more to services because they've struggled, and therefore people have seen them struggled and referred for support. That's recognised by the eating disorder clinical community. There are various kind of things in place to support people to access neurodivergent people to access services. There's a pathway called the Peace Pathway, which we've attended, a number of our clinicians have attended training on, about supporting people who are neurodivergent to access services. I think in relation to sensory sensitivities, as an example you gave, I think that can impact someone's experience of an eating disorder. There's an overlap there with avoidant and restrictive food intake disorder. So, and I suppose for us as a service working with eating disorders and not ARFID, it creates a clinical complexity for us, but we'll work with that. I think it's important to separate an eating disorder in the way in which we work with them, where body image is certainly a factor, and people feel shame and guilt in relation to food and how they look, whereas a eating restriction because of purely sensitivity is not an eating disorder. That's something that needs to be worked with in relation to desensitization, with kind of more consultation from dietetics and occupational therapy and pediatrics potentially. Sorry, does that answer your question?
Yeah, that does. Thank you. It's quite interesting. Thank you. Just move on to Councillor Needham's question. Thank you.
That was my question. You've just asked it.
This one.
It's all right, I've got another one.
Oh, okay.
Yeah, of course I have. So my question, that's not on the script, sorry. Welcome to Neurodiversity UK, here we are. So my question is, the front door. So when people suspect or think or they have concerns around eating disorders, I would suggest that they go to the GP first. Okay. So what level of training do GPs have, and are they empathetic and understanding of people with eating disorders, especially when a third of them are neurodivergent?
Can I start by saying that actually a big part of our service model is ease of access. So we would not necessarily encourage someone to go to a GP before coming to see us. So we have no referral form. We have no set referral criteria to make it as easy as possible for people to access the service. People don't need to go to a GP to be able to get support from us. They can phone us, they can self-refer. It doesn't need to be a referral from a professional, and that's really important to us in terms of helping people that are more vulnerable get access to support. I think in terms of the knowledge and skills that GPs have, I think that varies. It's really important to us that they have that message and that they have that training and awareness and support. So certainly in some practices, we've delivered promotional literature. We are working with somebody to access GP target training to make sure that their knowledge, sorry, that's not helpful, is it? To make sure that their knowledge is up to date and that we've got that. I think the challenge for us is it's a huge group of people and some of them will be more difficult to access than others. It's high on our radar, but I think for us, what's more important is that the message is out there that people can access us directly and we don't necessarily need to go down that route.
Okay, supplementary question time. Sorry, Lee.
I think which is also the back of the Young People's campaign around awareness raising, all that messaging in schools, etc. Just to note.
I'll not answer my question now. So my supplementary question was, and Lee's just alluded to that. So, and I'm not nitpicking, but reputation of CAMHS is for neurodivergence, it takes forever to get an assessment. And so, and that kind of like overlaps all the good work that CAMHS do, because people think, oh, it's going to take forever, so I ain't going to bother. So how do we get the message across then that it's an easy referral for this? How does that get out into the ether? What's your thoughts on that?
We can always do more work on this. I think it's important to acknowledge, and we've, as a service, when we've been struggling to meet clinical demand through COVID, our efforts to kind of promote the service and raise awareness of eating disorders in the service outside of the work that we're doing has been limited. We're increasing that now, but there's always a delay in terms of increasing service awareness to then access to service. We are we're engaging in things to, in terms of the edit campaign. As I said earlier, we're developing we're redoing a lot of our service information stuff. We're hoping to get posters into schools and colleges from September in the new term or shortly after if we don't quite get them ready before. But next academic year, early next academic year, and we're also working to promote an offer of training to the GP target events across Doncaster and Rotherham.
Yeah, that's great, and obviously the flip side of that is the more well known it is, the more people you get. So that has its own problem, doesn't it? Just in terms of neurodiversity, I wouldn't read a poster. Just saying.
Yeah, just to add to that, if I may, I think it's important not to conflict with the eating disorders. CAMHS pathway is very different to the neurological sort of pathway going in. And sort of from eating disorders perspective, the waiting times are actually really good compared to sort of other areas across the board. But obviously we are working on the neurodiversity pathway as well, but obviously it's quite separate.
Yeah, sorry, I don't mean to criticise that neurodivergent pathway, because I know that, and I'm really pleased to see that this is quick. But the question is, how do we get that message out? That's all. Because there's like a clash of cultures. There's what you're doing and your great work, and you're really working hard to try to make it accessible, and then there's what the public think.
Sorry, I just wanted to add a point. When you raised about the potential impact of increasing numbers of referrals to our service, the rationale is obviously that if people come to service quickly, they recover more and they recover quicker. From a service capacity point of view, that obviously translates to less time within service, less risk, less clinical time.
Can I just ask, is it easy to identify a difference of, like you explained, that if it's about being neurodiverse and having sensitive to around textures and everything, so do you think that there could be that risk of that person not being seen as quick because you know they're neurodiverse, so you might just think that it's along those lines and it might not be because you know that they're neurodiverse? Or is it all based on, I don't know, how do you differentiate between the two?
The short answer is it wouldn't make a difference. In terms of the Mead guidelines, as a risk assessment tool, is very much focused on physical risk irrespective of neurodivergence. And in relation to access to services, in relation to a kind of assessment for neurodiversity, it's important to note that the physiological and psychological impact of starvation on the human body and on your brain to some extent mirrors neurodiversity, particularly in relation to autism spectrum condition, in terms of kind of higher rates of or more noticeable kind of obsessional traits, kind of preference for structure, as well as sensory sensitivities particularly. So we, as a service, would always work with the eating disorder first, and not to ignore someone's perhaps preferences that may be related to their potential neurodiversity. But for us, the priority is always the eating disorder and supporting someone's ability to access that treatment, whether or not that's related to neurodivergence or something different. So in terms of, if you like, anything that we do to facilitate someone's assessment for neurodiversity, that would only be after an element of physical stability in relation to their state of starvation and their eating difficulties before we would consider whether or not an assessment regarding neurodiversity is appropriate for them at that point in time.
That's really useful, thank you for that. So we'll go to Councillor Cox's question, thank you.
Thank you. I'm straying again from what we've got. Firstly, I'd like to know what happened prior to, what service were available prior to 2015?
2017 So I was part of that service actually before it became a specialist service, and it was a provision that was within CAMS. So it was CAMS practitioners with a special interest in eating disorders.
There was something there. And then I have experience of a young person that's experienced eating disorders through psychosis, because he just locked himself away and wouldn't eat, which, as you've rightly said, then brings different traits out because he wouldn't eat. And he were in that room for nearly 2 months. And it affected us all as a family, obviously. The work that earlier interventions did were absolutely fantastic, but getting to CAMS didn't exist. It wasn't an option, and what the reason for that was because he was over the age threshold by 6 months. Nobody'd look at him, nobody'd say anything, so we ended up, like Councillor Needham said, we did have to go down the GP route. And all the GP kept doing is referring us back to CAMS that wouldn't touch him. So when we eventually got a phone number for early interventions, we explained what were happening, and they said, somebody will be with you on Monday, this one on Friday. And they were out there, even though they were stressed, because they knew what were happening, and they were absolutely fantastic. And what I see through a lot of your modelling that you've got here, which includes bloods taken in house, and are things that they're doing now, are you following some of the NHS early interventions model, if you like? Because the bloods that are taken within the house, within the home, it saves on the stress of the young person. It works absolutely fantastically. So if that person, like we've said, when they've not been eating, they don't jump. Well, he didn't want to see bright light. He wanted to be in a dark room, so all the curtains could be closed, and he would do it where he wouldn't leave the house. So are you following that kind of model? Because it really, really works, and the nurses that are doing that are absolutely fantastic.
Thank you. So the model that we follow is making it as easy as possible to give the best treatment that we can give. I think sometimes that can be conflicting. We have an illness where our young people often don't want to get better. So there's a challenge to begin with, in that often children and young people come to us not necessarily wanting to recover. In terms of the bloods in people's homes, that's not something that we're doing at the moment. We're in the process of being able to take bloods within our service. We already interpret blood results within the service, and we have the ability to access that through all the services in Ardash if we need to. But I think in answer to your question, our service is all about doing the right thing in the right place.
And I fully understand that. It'd just be nice to have that reassurance that it is following a model that we know works, and we know it works very, very well. Because same as you've said, Tom, about the once they got involved, you could see him changing after every visit, and they came every time, and you could see an improvement after every one, and they were quite shocked by the way that he had moved forward, and that's because of their engagement, and that's nothing else. But there's that, as were explained to us by the service, was that the quicker you get to them, the quicker you can improve it, and we saw that, and it's absolutely fantastic. I mean, I wish you all the very best, because we know how important it is. We know how complex it is, having lived through some of it, and absolutely hats off to you. But, you know, like Tim said, like lots of people have said, that contact, knowing that contact is there, is very, very, very important. And it doesn't appear to be as prominent as it could have been. I mean, bearing in mind that your service has been there since 2017, and you're looking at getting a poster in a school next summer, this summer, sorry. You know, I mean, it's a long time waiting for it. Thank you.
If I may just come in on that, I mean, it's just worth noting that, I mean, the Future in Mind policy change that was cross-party that came out in 2015 acknowledged all these things, Steve, and acknowledged the fact that nationally there weren't community eating disorder services that were separate from CAMS. So there was a whole load of money that was given under Future in Mind. But what was really interesting is at the time of doing it, they separated and ring-fenced a separate pot of money to develop a community eating disorder service. Future in Mind told us lots of things that we should follow and do, but it only mandated one thing, and that was that every area had to have a community eating disorder service. So, and at the time of doing that, obviously we'd created the team, we'd lifted it out of CAMS, there's a whole work done, and so there was a lot of promotion done as part of that at that time. I think where we're at now, as we've come out of the pandemic and we've seen an ongoing increase in need, there's something around making sure that people are aware of the services and the excellent work that's done, but also around upskilling our workforce more about early interventions, around identifying need, but also, again, making sure that they're aware of the service. So that's something, again, we'll take away from this.
I get that. Absolutely, Lee. Absolutely get that. I mean, the thing that we saw at that time, and it was just after pandemic, you know, everybody's getting out and about. The young people are socialising again. They don't know how to deal with it because in some cases they've gone to a new environment, new faces. They've not seen these people before. But what we didn't see is anything in places such as New College. There were nothing in there. They ended up kicking him out because they said we can't deal with him. Sorry, you know, I mean that is reality. So getting into those places is critical, and getting to the young people is critical.
Can I just say that pre-COVID we did a huge amount of training and awareness into schools and education settings. It was obviously limited by our capacity and capabilities during the pandemic. Also, just to kind of highlight that Wendy alluded to it earlier, that typically, not always, but typically, many young people that come to us haven't self-referred and aren't necessarily wanting to come. It's often the adults that are around them that are referring and bringing them. And so our service promotion has tended to focus on the pastoral teams, for example, within education settings. And we have done a lot of training and awareness for those types of groups pre-COVID and also during and since when it's been requested. In response to the pressures on the service, we weren't actively promoting it, but we have always responded and offered training when it's been requested.
I mean, that takes us into another question that is on paragraph 16 about working with schools and how it would work with schools. I mean, if it's requested, fair enough, but if it isn't requested, that need's still there. And, you know, I mean, that's a tricky one. And you can't go into somewhere without being asked if you want to go in. I mean, we don't want the young people going around flag postering all over the place. But that message needs to be out there. And it obviously wasn't at that time at New College because they got rid of him. I was sat in the room with him and they said, sorry, we can't deal with you. Yeah. Where he's planning to go back. He's trying to get his head in order to go back in, and they're saying, oh, no, don't want you. So, you know, I mean, obviously that training wasn't either requested or, I'm sorry to say, it wasn't given. I don't know.
I mean, historically, we have done a lot. I don't know quite where the time frame meets, but we have delivered training and awareness to New College a number of times from recollection to staffing teams. Predominantly, so I don't quite know where the difficulty in terms of translation comes from. We've also, as a service, because we are passionate about promoting early access to the service, obviously school nursing is provided by RDASH as a health provider, and we have equally kind of, you know, broadened out our service promotion training offer to school nursing within Doncaster, and also with Me in Mind, we've as an example, recently we accessed as a service some training for an intervention called the Body Project, which is focused on kind of preclinical presentations where young people are concerned about body image and self-esteem. And we hosted that as an eating disorder service, but it was delivered to us and with Me in Mind teams. And that's something that, I mean, this isn't that long ago, but it's something that we're going to be rolling out across the area, and it's a sustainable model whereby 3 members of our eating disorder team have been trained as trainers, so we can massively increase the workforce that's capable to deliver that intervention. That the model for that is very much that it's kind of involving me with Me in Mind teams and delivered in probably education settings. Yeah, there you go.
Just to add, Steve, that I think as well as the training that obviously Tom's spoken about, we've got more mechanisms in place now to be able to provide that kind of support and challenge to education settings where we don't feel they're necessarily not necessarily meeting the needs of the young people, but they're supporting the needs of those young people as best they can, whether that's with implementing training or strategies that they've already been given, or coming back to I think what you was kind of talking about, the academy model, you know, in terms of making appropriate adaptations for some of those young people, not only that have an eating disorder, but wider mental health and well-being kind of concerns. So we do put that challenge into education education settings now where we feel that they're not doing that, which unfortunately was not the case for yourself, but we definitely have got more mechanisms for that now.
It's great to hear that it's getting better. It sounds like it's getting better from every angle, which is fantastic. What I find quite upsetting and gets quite emotional is that all three of my kids have been through this process in one way or another, and the eldest one's 32. So it's been something that has been within my life, nearly all of it since having kids, and it's nice to hear it's getting better now. What happened when my eldest was needing help for being bipolar? And I know it's not eating, but when he was needing help for bipolar, what happened then? Because we just seem to be going round and saying, oh, it's getting better, oh, it'll be all right. But what actual evidence have we got to prove that this is moving forward?
Try and answer that. As you've said, the overall, it's been very difficult for so long in terms of school provisions, and obviously we've got the With Me in Mind teams that's continued to expand. They went into another, I think, 4 or 5 secondary schools this year, and then a number of primary schools as well. So that'll obviously help provisions in terms of schools and colleges, and I believe they're in New College now, and if they're not, they will be by next year. But that's sort of based on sort of national funding that we get given in terms of waves for the With Me in Mind teams. We've struggled for quite a while, I think it's fair to say, Kate, in terms of utilising the best mental health provisions within schools due to changing of staff and headmasters and Senko leads and stuff like that, whether it be from like the GDA pathway for a neurodiverse perspective or eating disorders or mental health. But it is better now, and I think with the implementation of sort of the Donny Dot website that we've got that highlights to young people and adults that these services are available, utilising Couth within schools, that's sort of another mental health provision, as well as the great work that the CAMS team are doing over at R-Dash. That it is evident now that it is better, but it could still absolutely be improved. And I usually try with my sort of little cousins to say, have you heard of this service or this service? And sometimes it's no. So I think it's about getting those young people to remember, for one, not just something to forget in assembly that a service is available, but also utilising services like Doncaster Parents' Voice. The parents are also aware of it. So if they're aware of the service, then they can challenge the schools if they're not providing that access into whether it be CAMS, With Me in Mind, whatever that might be.
I mean, obviously you can't answer that question, can you? Because there's no evidence of it actually getting better over that length of time, from my eldest son 32 years ago to now. There's no actual evidence in anything improving. And what I find really shocking is that it's our young people that need this support, and they need it for lots of reasons. And what got both me and my wife is that obviously we're elected members. We were trying to look for ways to support our son. We couldn't find them. We couldn't find a way forward. We were stuck. We were told the only way to get him any help was to section him.
And I know that it's really emotional for you, Steve, but I don't want you to go down too much of a personal road.
I'm fine. It's just, I mean, that from us being elected members, you'd think, hang on, we direct people in towards support, where, when we're stuck, what do we do? Because we was just stuck. We had nowhere to go. We happened to find a phone number, and I rang it. And it was more good luck than good judgment.
So appreciate what you're saying, Councillor Cox. I think there are two things going on that with some of it we can address locally, and some of it is out of our hands. Some of that's relating to national policy decisions that's driven us to the point that we are. We can have a big debate around funding. We can have a big debate around the SEND policy. and the transformation that's needing around children and young people with special educational needs, mental health need, etc. So there are some stuff that is out of our control, and we need to do the best that we can locally. And I think, unfortunately, and this is awful, is that your family experienced some of that, because in terms of the translation of policy and how we do that. The second bit that we are charged with and that we take from what I can hear from my colleagues in health and, as you know, from ourselves, is the stuff that we can do locally, the things that we can improve locally. And I, as a director of children's services, I feel quite strongly that the dialogue between us and our health colleagues are far improved. Schools are far better engaged. Is it perfect? Absolutely not. But can I see a difference in the system changing, the system listening to what's going on? Absolutely. I think neurodiversity is a big policy driver at the moment for us nationally. That, you know, we're going to see big changes, I think, in neurodiversity pathways, what that looks like as part of a SEND transformation program. I also think that CAMS and mental health, mental health is a priority in terms of policy. So again, I think we will see, hopefully, an improvement in how we deliver things locally. So I'm hoping that that gives you a little bit of hope, maybe not. And I'm really sorry that your family has experienced the trauma that you have, because it must have been horrendous.
Thank you, and it has, but it's obviously too late for us because that ship sailed. But you know, we just don't need other people getting on that ship in the first place, because it is absolutely horrendous.
Thank you. I think one other thing that we wanted to talk about is, why do you feel that there are recruitment issues in your area?
Yeah, again, it's part of the national picture. I think I alluded to it a little bit earlier in terms of the Children and Young People's programme for eating disorders was launched nationally. There was investment in the workforce at that time, and up until COVID, there was I think enough of a workforce to fill the posts that were there. I think the increase in demand on services wasn't then matched by the skills in the workforce, but the ICB has had a community of practice over the last year or so, James, is that right? And one of the work streams within that is specifically focusing on workforce and workforce development. So there are plans regionally to kind of support more people in their clinical training, learning about eating disorders, perhaps being interested by it, and perhaps ending up working within eating disorder services. For us as a service, we've also been really, I was going to say aggressively, but no, we are, you know, creatively and assertively offering placements. So we do have lots of colleagues who perhaps are already qualified who will come and join us for assessments, so they learn a bit about our service. We offer psychology placements, we offer nursing placements. So you know, we're doing what we can locally to increase, and development posts as well. So we've, for example, where we've struggled to recruit to a kind of a more experienced nurse, we'll offer a preceptorship post where we would get a newly qualified and train them into a more experienced role within our service. So yeah, we're doing what we can to make our service an attractive place to work.
Thank you for that. I'll just go to Councillor Needham.
Hi, thank you. We've had a tremendous discussion and it's been really informative, but there's more questions, I'm sorry to say. So we spoke about young people, we spoke about access to service, we spoke about individual reasons being vast and varied as to why young people have to live with eating disorders. How much support is given to family and friends of the children and young people? Because actually, if we're talking about networks being the best way to support families and developing networks, then the people within the network, and primarily in this question the family, need to know how best to support their family member. Can you explain a little bit about how that works, please?
Yes, so our baseline first-line treatment is what's called family therapy for anorexia nervosa. If we're talking specifically about anorexia, it's a family-based approach, and that includes bringing the whole family in. And by whole family, I mean the people that are directly caring for that young person. We recognise that eating disorders need a whole family approach and that they affect the whole system around the young person. I guess more broadly outside of that, we offer things like multifamily therapy, which again brings in the whole family for a 4-day course with us to think about impact on families, to think about family well-being, to think about the wider system around a child or young person and what they might need and how they might stay strong to help their family. We offer support groups. We can offer work for siblings if that's appropriate or necessary. I'm just trying to, I think that probably covers it as a starting point.
Okay, thank you. So I'm interested in peer support and support groups. So how do you facilitate that? Do you have providers to do that, i.e., family partnerships or whatever, or is it something that you, because of its bespoke nature, is it something that you do yourself?
So peer support is a little bit trickier in eating disorders given the competitive nature of the illness. So
the question is for families, though.
Do you want to pick that up?
Yes. So I think multifamily therapy is a good example of where we've successfully been able to do this. So I think families who, as Wendy was saying, it's a 4-day course, which is as an adjunct to a family therapy for anorexia treatment, which is the clinical recommendations. Parents that have been through that often develop links, and often they don't want the supportive services to keep that peer relationship there, but it is also something that we've offered in terms of, if you want somewhere to come in and meet, then that's something that we could provide. We have a number of times offered we've called it various things such as tea and talk. I've forgotten what the coffee equivalent was, but they are... if you like, we've tried to take it out of health services a bit and into the community as a non-clinician-led peer group. They tend to work for a little bit and then die down, I think, because parents develop relationships and then just go, well, should we meet for a coffee outside of this forum? So that's an ongoing thing that we try and provide. Sorry, was that? Oh, yeah. And also we've provided an online support group as well. So we've done that in face to face and online for parents. Yeah, and we're looking. We've adjusted our consent into service form as well to allow people to opt into an information sharing email so that they will get email. Email notifications whenever those groups are running, because historically recruitment to those has been a bit tricky.
Thank you. Yeah, I think it's good to hear that you do have the multifamily therapies and you want to equip those friends and family as much as you can, I presume, to help that young person. Do you want to come in again?
Yeah, it's just to highlight that is an absolutely fundamental function of our service. The research indicates that if you work with the family and support the family to support the young person, that it's twice as effective and takes half the amount of time. So it's really fundamental that we're involving parents, carers, and families.
Thank you. I think just to round it up and ask a last question. So you've explained that when you started your work and you've got your department and service, and then the Youth Council did their little bit, I presume separately, and came back with these figures that eating disorders is really prevalent and a concern for many young people. And you're talking about posters and changing the way that you might get that message out there. Just wondering, are you working with the Youth Council on that? Would you be running it past them? Would they be designing posters? Just wondering how much collaboration might be taking place there. Thank you.
Yes, we We have done a little bit in the past. We collaborated with them on their edit campaign when they came to visit us, and we have at various times, for example, Rotherham Youth Council. I know this is Doncaster specific, but patient and young people voice has been prevalent in lots of our service developments and things throughout our service history. We also, separate to the Youth Council, have some ex-service users or perhaps patients that are nearing discharge from our service and recovery who are willing and want to kind of feed into any kind of service developments, whether that's promotional material or sitting on interview panels, etc. But it's something that we're really keen to develop more.
Yeah, I think it'd be useful to use the Youth Council and their knowledge as well, because I know that obviously they don't represent every young person, but that I think we all can see from the earlier presentations, and having the Youth Council in the chamber, I think it energises us all really, and gives us that different perspective. So thank you. Before I close the meeting, I just want to go to recommendations and say that the panel is asked to give consideration to the information provided within the attached presentations and reports, and to note the current challenges. I'd also like to ask sort of in the recommendations that we get some figures, because the report doesn't give us any figures over the last 7 years of how many people are presenting with eating disorders. And also, I would like to recommend that eating disorders maybe is revisited at the Health and Wellbeing Board. I think it could be useful for that to take place, and speak to the chair about that anyway. But also to support by championing services, and I think we need to improve on service and shared assessments, and to help lobby locally and nationally, and do the best that we can do for our young people in Doncaster. So thank you everybody for your attendance today. I'd like to close the meeting. You're going to tell me that, aren't you? Thank you. Thanks a lot.
No, we've got work plan.
All right.
Yeah, Chair, Chair, just very quickly, it's there for noting the work plan and the Council's forward plan of key decisions, Chair. It's just there for the panel to note. Thank you.
Thank you, that's noted. Thank you, Christine. The meeting is now closed.